Hello, hello the world. Thank you very much. Welcome to the Sonoscanner webinar. We're very glad to be with you today. Paola, if you can click on the PowerPoint so I can start live broadcasting. I'm very pleased today to introduce you Dr. Tomislav Petrovic, or Petrovic, as we say in France, who's a very well-known physician in emergency department in France, in the Paris region. He has been president of WinFocus for years, the institution training all the emergency physician on ultrasound technology. And we are very honored that he accepted to animate this webinar in English in order to introduce you to the abdominal scanning and beyond the scanning in emergency situation. It will be very interesting to listen what he has to say, and you will also have some live demo during this exam, during this webinar. Just a few words about Sonoscanner. As you know, we're the leader in the handheld HD ultrasound scanners, but we have a full range of products that we offer to the customers. We have a premium ultrasound device called OrchioXQ with a big wide screen of 21 inches and 4 active probes, which is designed for intensive use. We have our bestseller high-end portable ultrasound scanner, T-Lite, which features HD probes for confidence in your diagnosis and dedicated customized reports. It's very popular when you have regular uses of your device, like 10 exams a day in cabinet, in small clinics office. And finally, we have a range of ultra-portable HD ultrasound, the U-Lite that most of you already know, and the T-Lite that we just introduced to the market with great success, and that we will use today during this live examination. T-Lite is the first handheld tablet ultrasound. It's the only ultrasound that integrates the 5F, a full day of scan possible with up to 8 hours back-to-back scanning with this device. A full probe range. You can accommodate up to 11 probes with this device, from phase d'arrêt to endocavitary, with a choice of high-end linear probes and specialty probes such as hockey stick. There is a full ease of use, because the interface is very simple to use with just a touchscreen button and similar to all your electronic devices. A full range of Dopplers. You have the color Doppler, the power Doppler, the tissue Doppler, the pulse wave Doppler. This way you can do whatever scanning you want. And finally, you've got all you have a full screen display with a 10-inch big monitor screen. The reason of Sonoscanner's success is based on 5 pillars. First of all, our device integrates a very worked interface to provide you a huge ease of use in your everyday practice. But as the company has been founded by a physician, we really care for the image quality. We believe that you deserve the best image quality possible, and that's why all our system integrates HD image rendering. We provide you with a full workflow solution, from scanning to integrated reports, which is very important if you need to refer to some other physician, if you want to be paid for the scan you just met. You often, in the countries where you all live, you have to provide a report, and it's integrated in your device. We always find financing solution for you to assist you in getting this latest technology, and we bring you state-of-the-art technical and medical support. Technical through dedicated engineering force that can answer to any of your technical questions, and medical support by providing you some facility training, some workshop here in our headquarters in Paris, or now with webinars that we are doing like this evening. All the team of Sonoscanner is at your disposal to discuss any aspect you may want to address, from planning on-site demonstration, answer any technical specification question you may have, study together the budget of your acquisition, or plan your training. So do not hesitate to reach out to us. We'll be happy to assist you. But enough about this Sonoscanner part. I give the microphone to Dr. Petrovic. Thank you very much and see you later.
Good evening or good morning. I don't know exactly where you're connecting from. So I'm Dr. Petrovic. I'm working in a small part of the world, which is close to Paris. I suppose you know Paris. It's somewhere... attends, ça marche pas. D'accord, mais c'est pas grave, la vidéo marche pas. Okay, we'll see further, because this one is not working correctly. Doesn't matter. I'm an emergency physician working in an emergency medical service close to Paris, in the northeastern part of Paris. And I'm the past president of WinFocus and actual president of WinFocus France, which means it's the French part of WinFocus International, who is providing all over the world courses about ultrasound life support, or also long ultrasound, or many other models that you can afford, that you can pursue all around the world. We are present in something about 50 countries in the world. In France, we have a nationwide number for emergency medical calls that are reaching by the number 15 call centers all around the France, and each district, we have 95 districts in France. Each district has its own call center. When someone calls for a medical call to the call center, he's mandatorily taken in charge by a physician, who will do a first diagnosis by phone and then send abroad different means he has at disposal. Could be a general practitioner, could be a light ambulance, police department, or fire department for first rescue teams, or also specific ambulances that are staffed by physicians in France, called MIQ, Mobile Intensive Care Units. In our district, we have 5 stations spread all around the district, and in each station is staffed by 1 or more mobile intensive care units. Each mobile intensive care unit is staffed itself by a physician, a driver, and a nurse. Once the patient is examined, once the diagnosis is made, the treatment begun, the physician on field calls the physician in the call center, and the physician in the call center chooses by the report the exact place where the patient should be carried. So it's I'm talking to you about this because thinking about ultrasound is thinking about all the different steps of the taking charge of a patient, of the management of the patient, whether out of hospital or in hospital. Out of hospital could be like this for an emergency patient, a critical patient, but could be also in a general practitioner's office, so that he could use also ultrasound for a first diagnosis and then orientate correctly the patient, or treat more correctly the patient, and we'll see why later. In France, we have 446 mobile intensive care stations spread around the country. And as I told you, each MICS, M-I-C-S, has its own mobile intensive care units that can be spread in less than 30 minutes towards the patient. It means about 7,500 interventions per year, which is quite a lot. And this means that we have across 750,000 critical patients that we are taking in charge every year in France by this means, by emergency medical systems. J'arrive pas à passer, okay. in-hospital services are at the number of around 645 departments in hospital, and they're facing about 17 millions of passing through patients. So when you figure about the huge amount of patients nowadays is more about 20 millions because it's rising every year. You can think of how patients can be taken in charge in the pathway in the emergency situation. So here you have an example of the pathway where the patient is coming to the hospital and facing all the different steps of his management in the hospital. And we'll see that at each part of this management, ultrasound can be valuable if used in a short time frame to achieve gross pathologies that can really enhance his pathway through the emergency department. We did two surveys, one in 2010, one in 2015, to see how much ultrasound devices were available in the different services, and we faced an incredible increase in 5 years. The next will be in 2020, next year. And we went from 50% of the in-hospital emergency department where an ultrasound machine was available to 75% in 5 years. So I think that nowadays might be that all the emergency departments are staffed with an emergency ultrasound device or ultrasound device at home. In pre-hospital settings, a little less, but it's increasing also. So nowadays, probably that half of the MICUs are equipped with ultrasound devices. So it's for those who think about the market, it's a huge market to be equipped with ultrasound devices. Ultrasound has a long story. If you know about the story, this is the first machine that was designed for clinical use in the patients. It was somehow difficult to carry this machine, as you can see, but it was called sonoscanner. So you see the history of sonoscanner is also brought from this type of machine. This was more of research machine, but it was already able to give some images. And then what evolved a lot was the probe. And nowadays the probe that you can hold in the hand were very large, very heavy. They needed a specific arm. Nowadays you can hold it in your arm and do the scanning by your own and in real time. This is what was really the difference, is that you can do it in real time. This is the difference between ultrasound and a scanner, a CT scan, because in CT scan you have a one shot, a single time frame, while with ultrasound you can do many examinations, and during the time from the beginning to the end of the management of the patient and from head to toe. And we will see some applications a little later. You can even have machines that can be put in your pockets. So this is something that is quite interesting. And here you have a panel of the different machines, and on the top part is the sonoscanner T-Lite that we'll use a little later. We'll use a device that you extracted from the T-Lite. Unfortunately, the videos are not working. Are they? Oh, they are. So you see that you can do also with those ultralight machines, pocket machines, quite efficient images. You can even use ultrasound abroad. This means on remote. Here you have two samples. The first sample is just by plugging your ultrasound device on the web, and you can see here on this image. Oh, I'm getting out of the frame. On the left image, you can see how ultrasound images can be sent. You know that everybody's using every day the internet. So this is also done by internet, and you can also use it in space. For those that will travel one day in space, you can use it in space. This is the device that was used by our French astronaut a few months ago, and it's a sonoscanner. So those devices, portable devices, can also work out of space. So this is interesting. What are the evidences? You've heard about the FAST protocol probably, which is dedicated to trauma patients. FAST meant at the beginning focused abdominal sonography for trauma. Nowadays is focused assessment sonography for trauma. And just on this topic, there was nearly 500 papers published, showing nearly every time that with ultrasound you enhance your clinical capabilities and you enhance your diagnostic, therapeutic, and orientation capabilities for the patient, which is not just a tool or a gamepad. Is also something that can enhance the management of your patient and shorten the time that the patient will be in your hands and reach faster the ward that the patient should afford. When we look at the whole publications on clinical ultrasound, there are thousands of publications, and they are increasing by year and still increasing, and probably that in the future ultrasound will really get deep inside the clinical management of our patients, not only in emergency. I'm not talking just about emergency, I'm talking about general practitioner, I'm talking about elderly physicians, I'm talking about pediatricians, I'm talking about anesthesiologists or intensivists. In France, intensivists are using ultrasound for decades, and they're really enhancing their skills while using ultrasound. Just to talk to you about one publication that was published in 2017. It was a one-day registry of how emergency departments in France, or out of hospital or in hospital, were using ultrasound in their daily practice. And it was from midnight to midnight, so 24 hours, just 24 hours. It was a one-shot picture of one day in the year. And we looked at how ultrasound impacted taking the management of the patient. So it was done on a panel of emergency departments, those who were already using ultrasound, and we asked them to note systematically what they were doing with ultrasound and what they thought ultrasound brought to them and to their patients. What we could see is that they did a lot of cardiac ultrasound, so it's a huge part of emergency ultrasound and also emergency medicine, but also different parts as abdominal, as lung ultrasound, which is increasing because nowadays we cannot replace the stethoscope that we're using every day, but we can really enhance the possibilities of this device by using ultrasound and bringing so many more information with ultrasound that are directly impacting the management of the patient, instantly managing the management of the patient. I don't know if you see correctly the numbers here, but we can see that at each part, diagnosis or therapy or also orientation of the patient, ultrasound impacts the management of the patient. It impacts also the decision of making further imagery, radiology or CT scans. Sometimes it brings you enough information to say that you don't need anything else. Sometimes it brings you information that are more precise and bring you to more precise extra examination, which is really also very interesting. So it's not only a tool for diagnosis, but also for therapy, orientation, and also for monitoring, because one of the purpose of ultrasound is that you can do it from the beginning to the end of your taking in charge and follow the evolving of your patient and see how the therapy is efficient, how your clinical examination is modified through the pathway of your patient. So in emergency, but also in general practice or clinical practice, we can imagine that we have two different scenarios, the trauma patient and also the medical patient, but each time you can use many different parts of the body to be scanned by ultrasound and then integrate your medical reasoning to do a proper diagnosis and then choose the right therapy and the right orientation of your patient. It's more problem-based than organ-based, the way that ultrasound was used previously by other specialists, targeted or on the abdomen only, or on the heart only, or on the uterus only for OBGYN. Clinicians, as general practitioners or intensivists or emergency physicians, are in the need to have a global image of the patient. Afterwards, I will show you how easy. Okay, I'm a kind of expert, not considering myself as an expert, but I'm kind of expert using ultrasound every day. So the things that I will show you might seem to be simple, but a training is needed for each of those parts that I will show you. Even though the training is very short, very fast, doesn't need a high skill. We did it with children, and children are able to learn this also. So I think that us physicians are also able to learn it. This is just the different ways of how to learn things. You can learn for several hours, you can learn for several days, you can learn for several years. But anyway, you are always practicing and always learning with ultrasound by integrating it further in your general practice. Here is just an image of how, during a 2-day course, the skills of the trainees are increasing during the course, because we're doing a loop. We're always training and practicing the same things we're teaching from the beginning to the end. And you can see here that the difference between the trainers is quite close to zero at the end of the training from the 6th or 7th attempt. It's really something that is getting similar for everyone. So don't think that the intra-operator and inter-operator difference is very high. It is when you're doing very precise things, but when you're trying to find macro events, gross events, for example, like intraperitoneal hemorrhage, or pleural effusion, or pericardial effusion, these are things that can be achieved very fast and very easily with most of the ultrasound devices. This is the pathway that we can use in a trauma patient, and you can see that we can do ultrasound from the head to the toe. This is the first part of the taking in charge. Could be out of hospital with an ambulance. You do your ultrasound on the site, on scene, and then while going further, you can do the ultrasound during the transportation, adapt your therapy, adapt your orientation, change your orientation if needed, then bring your patient to the shock room or directly to the operating room. This happens more and more oftenly in stable patients. And then do the ultrasound during anesthesia or post-anesthesia in the ICU when the patient gets out of the operating room, and so on until the end of the management of the patient, from the outside to the inside and the outside again of the patient. So when we get a look to the pathway that I showed you at the beginning, you can see that at each part of this pathway you can use ultrasound, even probably in the future by nurses, because we are also in the world training nurses to do some of those ultrasound applications that they can use for a fast triage at the entrance of the emergency department. So if you have any question, I might answer questions for several minutes. Otherwise, I will go and show you how ultrasound can be fast, can be easy to approach, and we'll see different applications. Also, not only in the abdomen, but see some cardiac ultrasound, because you'll see that also you can learn about all of those applications that are usable every day. I will use this kind of probe, which is a convex probe. The convex probe was usually used by the radiologists for doing abdominal ultrasound, but you will see that with this probe we can do also long ultrasound or cardiac ultrasound. So when you begin to use a probe, you should use it until you need to change it for further examination. So it's freezed, isn't it? Yes. Let's scan it. To use a probe correctly, you need to put some gel on it, some marmalade, as it's called by Canadians. And the marmalade is used to avoid having air trapped between the probe and the skin. So it's just a mean between the probe and the skin to avoid the ultrasound not getting through. Okay, so I'm sorry it's a little cold. Don't forget that in winter you should warm a little the gel because it's quite cold. So here we're in the abdomen, and you see that the position of the probe is quite lateral for the patient. I'm not going to do a transabdominal probe. I'm doing a transthoracic probe on the right or the left side because this is the best window, acoustic window for everyday patients. This means that you don't need the patient not to have eaten something or drunk something. You can do this exam to all the patients, even those who had their meals just a few minutes ago. So it's one of the advantage. And see here the first image that I achieved here just by screening from up to down and from front to rear to find the kidney. Here you see in the middle of the image the kidney, and upwards on the left side is the liver. And this is the main image to find liquid in the peritoneum, free liquid in the peritoneum, free effusion, because it will get between the kidney here and the liver just on the left side. You can see also the diaphragm on the left side of the image, this hyperechogenic image line, which is a little curved, white on the image. And you can see the diaphragm moving while the patient is breathing here. So this is important for two reasons. The first reason is because you can see that the patient is breathing. That's the first one. And then you can evaluate the movement of the diaphragm and say if on one side the diaphragm is less moving than on the other side. So in a critical situation, it could be interesting to see if there is, for example, diaphragmatic paralysis. Upward the diaphragm is the lung, and so it's also the image that will be used to find a pleural effusion. And you see here the posterior cul-de-sac of the pleura, and if there was, obviously there is not here in our model, hopefully, you can see that there is no fluid, and we can also see if she breathes deeply. Can you breathe deeply, please? You see just the lung crossing in front of the probe. You can, yes, expire. That's good. So you see just with a small, fast achievable image, you can have a lot of information. And this side is the most sensitive side to find a peritoneal effusion, for example. It's called the Morrison's pouch. You maybe heard about it. The Morrison's pouch is the pouch situated between the kidney on the right side and the liver on the left side. And this is exactly where all the liquid, even a small amount, will get, because there's some adherence in the abdomen that will lead the liquid. In a patient supine like this, in a patient supine, the liquid to come in this pouch. On the other side, we have exactly or quite the same image, and to find it, we'll search for the left kidney this time. Here I was on the right. No, don't move. I was on the right side, and you see here I have the left kidney. I will decrease a little the depth just to see it a little closer. You see the kidney, and what is interesting is that the same image on the right and the left side can show you the kidney and see if there is or not a hydronephrosis. You see that with the easy image, you see not only the pouch on the left side here between the kidney and the spleen, which is called the Culler's pouch, and also the diaphragm. You see on the left side the white line that is occurring here, that is arising on the left side, is also the posterior cul-de-sac, the left posterior cul-de-sac of the pleura. So these are images, very simple, very fast to learn, very fast to achieve, that brings you so much information for a critical patient. Also for an abdominal pain, you can screen and see why the patient has an abdominal pain. If the image is normal, no liquid in the peritoneum, you already can bring an answer to the question. So when you see the kidney here, the white part is the sinus of the kidney. This means that it's where urine is collected, and when it goes then from the ureter to the bladder, if there is a retention, hydronephrosis, instead of being white, it will be black, because liquid on ultrasound looks black because there is no echo coming from liquid. And you could see in the middle of the sinus those different parts of the sinus pouches that are congruent, that they're getting each one to the other, and they're confluent, and this is the sign of hydronephrosis. It's really quite simple also to achieve. Being a general practitioner, sometimes you can figure out how it can be interesting to have a quick look on the kidney while a young person is coming to your office with a lumbar pain, a lateral lumbar pain, and you can see directly if there is a dilation or not of the sinus. So it's a few seconds you've seen. Then you can also see the famous Douglas pouch. The famous Douglas pouch is situated behind the uterus and in front of the bladder. Hopefully our model didn't go to pee a few minutes ago. I hope so, that there will be some urine in the bladder. And we have to go to the pubic bone and then bend down to the pelvis, and you can see in black here in the upper part of the image the bladder. You see the bladder, it's a little filled with urine, and just behind the bladder there is the uterus here. Let's try to enhance a little the image. Okay. The uterus will be seen easily here. We have a transversal view. This means that I'm cutting the bladder from left to right side, and here we have a longitudinal view, and you see here the uterus arising on the left side of the bladder here. This is the uterus body, the angle of the uterus, the comment on dit le col, je sais plus. Le col de l'utérus en anglais. Okay, it doesn't matter. The distal part of the uterus, and here the vagina. So we can also see if there is a pregnancy. So some abdominal pains in young ladies having some late menstrues, and that are consulting you, you can see directly if there is something in the uterus or not. So the Douglas pouch is behind the uterus. Don't consider the black part as a collection. Is probably more connected to the bowel. So the problem is that the bowel is taking a large part and containing also air, which is avoiding ultrasound to get through. So sometimes you will have to push a little. Don't push too much if the bladder is full, because you have some risks, and turn around these parts to have a good idea of the pelvic part of the body. Is this clear for you, for everybody, or do you have any question? See the uterus again. While you are in the abdomen, one part that you can also easily see is the aorta, and you probably know that in some countries in the world there is a prophylactic screening of abdomen in men, especially men older than 60 years of age, to find a AAA, an abdominal aortic aneurysm. So it's quite easy also because the aorta is quite superficial, and you can see it here. Don't think this is the aorta, it's the vertebra, it's the lumbar spine, and just in the upper part of the spine you can see the aorta, and on the left side the aorta, on the right side, on the left side the inferior vena cava. And you can screen the aorta until it spreads in iliac arteries here. You see that it splits in iliac arteries. So you can screen the entire length of the aorta upwards to the epigastrium, Here you are in the epigastrium, and you see the aorta, a large inferior vena cava, and a small aorta, and the diameter, normal diameter of an aorta, abdominal aorta, is less than 2.5 centimeters. You don't need here to measure. You just take the aorta on the right side of the screen, and you can see that it's less than 1.5 centimeters. So your aorta, lady, is quite normal. Once you're in the epigastrium, what is very interesting also to have a look to is the heart, because the heart is just above the probe here. Can you breathe deeply, please? Okay, I just ask the model to breathe deeply. And you have here the heart, and this image for me is enough to see if there is a pericardial effusion. In fact, not in this image. If there was a pericardial effusion, the heart would be much more obvious on the image, because liquid, when there is a liquid between the probe and the target you're looking at, you enhance the echogenicity of the target. Just because there is a liquid in the middle, it provokes a kind of window, acoustic window, that affords a better seeing of what is after it. So on the upper part of the image you have the liver again, and just upwards you have the heart. Okay, the image here is not so clear, so we could change the probe, and we'll try to change the probe, and you'll see that with this device changing the probe is quite fast. If you have to see the heart a little better, you have just to change the probe. You click it, and you will have probably a better image of the heart. Yes. You see? Tu peux respirer à fond. Ouais. Tu peux respirer à fond. Inspire à fond. Voilà. Et bloque ta respiration. See here, we can see all the cavities of the heart. On the left side of the image are the right cavities. On the left side of the image, the left cavities. And you can see the contractility of the heart, the global contractility. You can compare right cavities towards left cavities and say if there is cor pulmonare, an acute cor pulmonare or not. So you see, just on a simple, very fast achievable image, you can have a lot of information. If those images are not enough, you can go to specific cardiac windows, which are parasternal windows, like this one. Let's decrease a little the depth. And you can also see the posterior pericardium here on the deepest part of the image, the anterior part of the pericardium here, and cardiac cavities that are working quite efficiently. If you want to see the local contractility, you have to turn your probe 90 degrees clockwise and see the short axis image like this one. Let's try to find it correctly. Pas facile ta parasternal, petit accent. Here. Okay, when you see the heart beating like a rounded cavity, so you can clearly see if the heart is correctly contracting all around the cavity. And finally, you can do an apical one. Je vais essayer de la faire. Alors, ce que tu vas faire, c'est que tu vas tourner sur le côté gauche. Juste pousse-toi un tout petit peu que je m'assoie à côté de toi. Tac. And we have here a apical four-cavity image, which also can show you the pericardium, but you can more precisely do the ratio between the right cavities on the left side of the image and the left cavities on the right side of the image, and also see the global contractility of your heart. So we screened the abdomen, we screened the kidneys, we screened the posterior cul-de-sac of the pleura. Let's see how the lung is working. So I will change the probe again because the phased array probe, the cardiac, so-called cardiac probe, is not really designed to correctly do the lung ultrasound. I will just show you the Princept image for the lung, which is very interesting because it will directly eliminate a diagnosis, which is the pneumothorax. Okay, see the image, how it changed just by changing the probe and changing the preset of the probe. Okay, so here I'm situating between two ribs, decreasing the depth. Mettre au minimum. Oh putain, je l'ai vraiment pas les doigts pour ça, moi. So, je te demande de respirer un peu plus fort. Okay, here there are two acoustic shadows that are provoked by the ribs. The ribs are absorbing the ultrasounds and avoiding any echo coming from the back of the ribs. Just behind the ribs here is the pleural line, and you can see moving the pleural line here. Above the pleural line is the intercostal space and the subcutaneous tissue. So it's not moving while the probe is clearly fastened to the skin, and you can see a movement just beneath here, which shows that the lung is really the two layers of the pleura are close to each other. So it means that they are sliding one on each other, which means that there cannot be here a pneumothorax. If there was air in between the two layers, you could not see this movement. And the negative predictive value of pneumothorax is of 100%. So it's really, really very interesting. It's much more efficient than just using your stethoscope and listening to the lungs, because you can see directly the sliding of the pleura. So this is really one thing very interesting. And I told you just before that to see a pleural effusion, you just can go on the lateral part of the abdomen, transthoracic image of the abdomen. So here it's the same image we had before. I'll try to do it again. Okay, so you have here should be the kidney. Where is your kidney? Okay. C'est marrant, l'image est retournée. Here is the kidney. You can recognize the kidney here on the right side of the image. Let's decrease a little the depth. Okay. Vraiment très très fine. So the Morrison's pouch here. Okay. And just above here you have the diaphragm. Let's get another preset to see if the image can be enhanced. J'y arrive pas. Peut-être tu peux appuyer sur. Vous auriez dû me donner un petit stylo. Ok. Alors, tac. On va diminuer un petit peu, se mettre à 10 cm. See here the kidney, right? We can see that there is no hydronephrosis inside, and then slide the probe towards the upper part of the abdomen to see the diaphragm. Il y a des questions qui sont posées ou pas?
Non. Tout est clair.
Tout est clair. See here the diaphragm. So you can see again moving the diaphragm while breathing. And when she breathed deeply, you can see what we call the curtain sign. This means that the lung just came in front of the probe and shows you that the lung is, the two layers are in contact of the pleura, and that there is probably no pleural effusion either. If there was a pleural effusion, it would avoid the curtain sign and enhance the image that you can see above the diaphragm here. Okay? Just the last part of it. When you do an ultrasound examination in a stable patient, you can do also a hemodynamic evaluation. You have seen the cardiac functioning. You can see, you have seen the lung. In the lung, when there is too much water in the interstitium, you can see the interstitial syndrome, which is shown, fortunately, our model doesn't have any interstitial syndrome, but it's shown by vertical hyperechogenic lines called B lines. You maybe heard about that. And if you have more than 3 B lines in the middle of 2 acoustic shadows provoked by the ribs, then you can be certain that there is an interstitial syndrome. And interstitial syndrome means that there is too much water in the interstitium. For example, in pulmonary edema, the cardiogenic pulmonary edema, you have an interstitial syndrome, and you can see it really easily by ultrasound. So when you do a hemodynamic evaluation with ultrasound, you should merge lung ultrasound, cardiac ultrasound, and also inferior vena cava ultrasound. Previously, I showed you the aorta, which was, let's put some gel. Which was on the right side of the image. See here in the middle of the image is the aorta. Let's decrease a little the depth. And on the right side of the aorta, we have here the inferior vena cava. The inferior vena cava is directly connected to volemia, to intravascular volemia, or to right cavity's pressure. So if the inferior vena cava is completely collapsed, this means that there is a defect in the volemia, in the vascular volemia. So you can infuse your patient and try to raise the volemia. If the inferior vena cava is dilated, you can probably think that or there is too much volume, or that the pressures in the right cavities is much higher than it should be. The problem with the inferior vena cava is that it's very, very variable between patients. So you should not use inferior vena cava for the hemodynamic evaluation on its own, because it leads to a lot of mistakes. But when you're sure it's inferior vena cava, you can see here inferior vena cava getting into the right cavities. Let's try to. See here the inferior vena cava in transverse image, here on the deeper part of the image, getting into the right atrium. Okay, so you're sure it's the inferior vena cava, and once you have it in transversal, you should go in longitudinal. Here we have a longitudinal view of the inferior vena cava that allow you to measure its diameter. And the diameter should not be 0 and should not be fixed. And probably we don't need much more than this, or completely collapsed, which means that you should infuse your patient with some volume to increase the volume, the vascular volume, or it's dilated and fixed, and then you can think that the volume is enough, or the pressures in the right cavities are too much. So you can first look at the inferior vena cava, then you look to the heart. Still with the same probe, you can look to the heart. Let's try to do it. Tu vas inspirer encore une fois à fond. See here, with the same probe, I can see the heart. Okay, so I can see the contractility, I can see the rhythm, I can see if the right cavities are filled up or not. Then go for parasternal if needed, or especially on the lung, to see if there are some B lines. You see, with this probe, we can see quite correctly the lung sliding. Let's see. Non, c'est bon, bouge pas. Let's see the lung sliding. Maybe we will see it. Okay, vas-y, respire un peu fort. Okay, here, see the lung sliding, see the the two layers of the pleura. In fact, you cannot see the layers of the pleura. You just see the lung that is moving inside the thorax, and it's in contact with the thorax. So this really is important, because when you have a dyspneic patient, you can, by just one image, see, or just by thoracic screening, see if there is an interstitial syndrome, see if there is a lung sliding, see many things, also consolidation and pleural effusion. So with the ultrasound, you're much more efficient than your stethoscope, and probably much more efficient, and it was proven more efficient with than the chest X-ray. So if you can do that in your office directly or in your hospital, whether emergency or not, maybe there is some pneumologists with us. Hopefully, yes, and they could use this every day in everyday practice with a very good outcome for the patients. The sensitivity and the specificity of the lung ultrasound is much higher than the auscultation with the stethoscope or even with chest X-ray. It's compared to the CT scan, the thoracic CT scan. The advantage of the ultrasound is that you can do it how much you want, when you want, and repeat it on will whenever you want. So we're reaching to the end of our webinar. I hope you enjoyed it, and I would like to ask you, if you have any question, please to ask me. I can show you some different feature again if you need to go further. Do you have any question?
Not yet.
No. Do you have any question? No.
It was very clear. Did you use the HD probes? Yes, I think you used it.
Yes, I used the first one, the monocrystal probe. This one, yes, it was at the beginning. I will use it again, just to show that the probe is really very efficient. Peut-être que les programmes cardio et tout ça devraient être un petit peu plus. You can see here. Si j'appuie trop fort, tu me dis, hein, parce que j'appuie un peu. Again, here the inferior vena cava. Let's see if we can see it in longitudinal way. Here it is. Here it comes. See? Can you breathe deeply, please? You see, by breathing deeply, it collapses a little the inferior vena cava. The variability is also very important of the inferior vena cava, but unfortunately we don't have the time to go further in this. You should go for some training if you have the opportunity. Try to figure out WinFocus in your country, if it's present or not, or whatever the course, and don't hesitate to go to the courses. Don't think that this tool should be reserved just for some physicians. It can be used by any physician in any type of methodology of working, where they're out of hospital, and it's really dedicated to point-of-care ultrasound. This means that the physician who is examining the patient is the one who is doing the ultrasound. And it's not a comprehensive ultrasound. It's really dedicated to gross pathologies, to gross information that can impact directly the near future of your patient.
It was fascinating, doctor. Thank you very much. We managed in 1 hour to see many organs, to have a very good understanding of the FAST protocol, and I'm sure everybody enjoyed it. We've been told that there were some connection error. We're really sorry about that, but thank you for this feedback. We will improve it for next time. But we will share with you some HD recording of the session, so this way you can enjoy the image resolution and the expertise of Dr. Petrovic. It will be very useful. So thank you very much for being with us today. Take note of the next webinars. I know one is already planned for next week around cardio initiation, how to do some basic cardio scanning, a topic that we talked about today, which is very important. If you have some subjects that are dear to your heart that you want us to explain, any technical, medical subject that you think that would be interesting to benefit from a webinar, let us know. We'll be happy to build it up for you. If you're already a Sonoscanner user, thank you very much for your confidence. We hope you enjoy using our device every day. There is the Club Utilisateur, as we say in French, which is made for you, by you. And it's a place where you can exchange your thoughts and suggestions. It's a very useful club that we have. If you're not yet equipped, please get in touch with us. We have a network or more than 35 dedicated distributors that can assist you locally, and that will be very happy to bring you the support and the service you deserve. So thank you very much. Have a nice evening or a nice day if you are in the States. Happy Thanksgiving, and we'll see us very soon. Thank you.